Good afternoon, everybody. First speaker today, Professor Ghada El Kanishi, Professor of Internal Medicine and Nephrology at Surah Faculty of Medicine. She will speak about very important topic in hemodialysis, facing us a lot of patients suffering from diabetic end-stage renal disease. She will speak about the management of diabetes in hemodialysis patients.
Diabetic patients on dialysis have a higher mortality than the non-diabetic patient. The main cause of mortality in this patient is cardiovascular disease. Good control is associated with better survival in this patient, especially if this control is achieved in the first 6 months after initiation of dialysis. What are the factors that affect the glycemic control in diabetic dialysis patients? These patients are anorexic. These patients have poor gastrointestinal glucose absorption. In addition, insulin metabolism is affected by end-stage kidney disease. At first, there is increase in the insulin resistance, and later, insulin clearance is affected as well. These patients have a higher risk of hypoglycemia when reaching the end stage, and the dialysis can affect the drug clearance. How can we manage diabetic patients on hemodialysis? Management will include either oral hypoglycemic or insulin. Oral hypoglycemic drugs, we have different groups of oral hypoglycemic acting on different parts, either increasing secretion of insulin by the pancreas, affecting the insulin sensitivity, decreasing absorption of glucose. We have many groups of oral hypoglycemic. The challenge in using this oral hypoglycemic in diabetic patients, that many of these drugs have not been studied, and many drugs are contraindicated. So if I have a patient with type 2 diabetes starting dialysis, and I need to give him an oral hypoglycemic, what drug will I choose? First, sulfonylureas is one of the oldest groups used in the management of diabetes. They act by increasing insulin secretion. However, they have a high protein binding, so they can be effectively cleared from the circulation by hemodialysis. In addition, many drugs, as we see, can displace sulfonylurea from its protein binding and thus increase the risk of hypoglycemia. The only drug which can be used in patients with hemodialysis, the only sulfonylurea, is glipizide. Glipizide can be used with safe dose starting from 2.5 to 10 milligrams per day. Meglitinides has the same mechanism of action. It increases the insulin secretion by the pancreas. We have two groups. Meglitinides is not used in hemodialysis patients because although it is hepatically metabolized, but active metabolites are secreted by the kidney. So ribagrenine is the drug to be used in patient on dialysis safely, as less than 10% of the metabolites which are inactive are excreted in urine. Metformin or biguanide carries the risk of lactic acidosis. If you give your patient metformin, you are putting the patient at the edge of death. Lactic acidosis, although it is a rare complication with metformin, but it carries a high fatality. Fatality may reach up to 50% of the cases. TZDs or Thiazolidinediones, the only drug available now in the market is the pioglitazone. Apart from CKD, TZDs carries a high risk of heart failure as a complication, loss of bone mass, especially in female, and it was accused of increasing incidence of bladder cancer in patients using pioglitazone. So the main warning of TZDs is fluid retention, and that is why caution should be taken in patients with high susceptibility to heart failure, including diabetic patients more than 10 years. So TZDs is not recommended, not because of its pharmacokinetics or because of affection due to renal failure, but because of fluid retention. Alpha-glucosidase inhibitor act by decreasing absorption of glucose, and they are better avoided in patients with CKD and end-stage kidney disease. DPP-4, this is a new group of drugs. Some data concluded that it is safely and effectively can be used in CKD. Dose adjustment may be needed in many of these drugs. We have many DPP-4, sitagliptin, saxagliptin, linagliptin, and vildagliptin. The only drug which is not renally metabolized is linagliptin. Linagliptin is metabolized mainly by the liver, and the excretion is through the bile. So it can be used safely without dose adjustment. Sitagliptin, on the other hand, we have to decrease the dose to 1/4 the normal dose, which is 100, gives the patient 25. Saxagliptin and betagliptin, we give the patient half the dose given in normal personnel. Saxagliptin, on the other hand, is cleared by the circulation. 1/4 of its level is cleared by the circulation, so it is better to be given after the dialysis session. In conclusion, DDP are effective and they have less incidence of hypoglycemia. They carry the advantage of prevention of inflammation and atherosclerosis, but until now, the effectiveness of DDP-4 had not been reviewed. We should, in the use of DDP-4, there are some reports about increasing or precipitating acute kidney injury in patients receiving DDP-4. DDP-4 has also a very common side effect. It causes nausea, and our patient with end-stage kidney disease is already suffering from nausea. So this can add to the limitation in the use of DDP-4 in hemodialysis patients. Exenatide are contraindicated in patients with on dialysis, as well as liraglutide. Sodium glucose transporter, which prevent reabsorption of glucose from the tubules and result in its glucosuria, are also contraindicated if the GFR is less than 30. So in conclusion, oral hypoglycemic are not safe in patients with dialysis. The safest drug to be used are glipizide, Biguanide, and linagliptin. The second is the use of insulin in this patient. In patients with hemodialysis, the use of insulin is preferred than the use of oral hypoglycemic. We should take in consideration that the insulin dose may change during the transition from the end-stage kidney disease to the dialysis stage. The insulin dose should be adjusted according to the GFR. In patients with GFR less than 10, we decrease the dose to less than 50% of the normal dose. This is the same for patient on dialysis, and the dose can be titrated or modified according to the glucose monitoring. We have many insulin preparation. We have the human insulin with a rapid acting or the long acting NPH, and we have the insulin analog. Insulin analog has the advantage of shorter duration and shorter time of onset. So it starts earlier and it is cleared from the circulation more rapidly. So which insulin is preferred? Insulin analog are preferred because they provide a good glycemic control and decrease the incidence of hypoglycemia than the other conventional or human insulin, but the cost is the barrier. How can I give insulin to this patient? Insulin can be given by many ways, but the preferred way in this patient is to give a basal bolus insulin. So we give a base of insulin, usually given at night, either NPH or analog, insulin analog, and so on. And we give the short-acting insulin before meal. There are some problems in this patient. First, what is the goal of glycemic control? How to monitor the glycemic control? And this patient usually suffer from fluctuation of their blood glucose level and increasing in incidence, especially of hypoglycemia. What is the goal in this patient? The goal in this patient is hemoglobin A1C ranging from 7 to 8%, but this range still depends on the risk of hypoglycemia and the presence of comorbid condition. So if the patient is young with no comorbid condition, we can use 7 to 7.5, while in older patient with associated comorbid condition, we raise the hemoglobin A1C to 7.5 to 8. Hemoglobin A1C has been associated with increasing mortality. We have a U-shaped curve. So mortality is increased if the hemoglobin A1C is decreased less than 5.4, and it is increased when the hemoglobin A1C is increased above 8.5. How can I monitor the long-term control of this patient? The question is to use hemoglobin A1C or to use glycated albumin. Why? Hemoglobin A1C is not accurate among these patients as in the general population. These patients are anemic, have a reduced lifespan of their RBCs. They may take erythropoietin, which accelerates erythropoiesis. The newer RBCs, the young RBCs, has no time to contact with the glucose to form the glycated hemoglobin. In addition, it was shown that hemoglobin A1C may be accurate in patients on dialysis in the range from 6 to 7, while if this range increased to 7.5, this may overestimate hyperglycemia in end-stage kidney disease. Glycated albumin, on the other hand, is not free from disadvantage to use in this patient. It assess the glycemic control over a shorter period, about 2 weeks. It is not reliable in patients with proteinuria. There is no long clinical trials evaluating the relationship between glycated albumin and the complication of diabetes. This is in contrast to hemoglobin A1C. We have all our data using the hemoglobin A1C to monitor or to assess the complication. Glycated albumin, on the other hand, may not be accurate. Hemoglobin A1C, on the other hand, may not be accurate if the hemoglobin level is less than 10. And in these cases, glycated albumin is better used. Although some literature concluded that glycated albumin provide a better measure for glycemic control as this one, others concluded that hemoglobin A1C was most closely associated with the mean blood glucose. So, which is better? Glycated albumin, as regards glycated albumin, we have limited data. We have absence of clinical trials based on glycated albumin. It is expensive and tedious. So the cornerstone until now is the use of hemoglobin A1C, which is a good choice to monitor the glycemic control even in dialysis patients. The second is the fluctuation of the blood glucose. We have many causes that result in hypoglycemia in this patient and other causes which may result in hyperglycemia in patient on dialysis. Hypoglycemia, the mean of the area under the curve on the day of treatment, on the dialysis day, is relatively lower than the non-dialysis day. We have many causes, some of which are related to the anorexia, related to the disease, decrease in renal gluconeogenesis, and decrease in insulin clearance. But one of the most common causes is the glucose loss in the dialysate. It has been said that glucose-free dialysate results in approximately 40% of hypoglycemia in patients with or without diabetes. So now the new trend is to optimize the hemodialysate composition. We use, I think until now in Egypt, we use glucose-free dialysate, but the FDA have approved the use of 100 milligram glucose, which sure will decrease the incidence of hypoglycemia. The fear of using glucose containing dialysate was the fear of bacterial infection. But glucose, dialysate containing 100 milligram have shown efficacy in treating such patients without hypoglycemia. Hyperglycemia, on the other hand, may result from many causes, including patient-related causes like inadequate insulin dose or non-compliance or poor absorption to the diabetic state itself, to increasing insulin resistance in these patients. This hyperglycemia rarely results in ketoacidosis. So ketoacidosis is rare in patients on dialysis, while hypoglycemia is a very common complication in this patient. Ketoacidosis in patients on dialysis is characterized by minimal symptoms. The patient is oliguria and so hypovolemia and marked hypernatremia does not occur. This patient is hypervolemic. The very characteristic that this patient is hyperkalemic, which may reach a lethal dose, a lethal level. The management of diabetic ketoacidosis in such patient does not depend on fluid. It depends on insulin infusion. Emergency hemodialysis may be considered if pulmonary edema, metabolic acidosis, or severe uncontrolled hyperkalemia is present. Some patients may suffer, or some of our patients may suffer from alternating hypo and hyperglycemia. At the day of dialysis, the patient may have hypoglycemia due to loss of glucose in the dialysate. After the dialysis session, the patient may be hyperglycemic due to release of the counter-regulatory hormones, plus increasing the appetite of such patient after the hemodialysis. So there are day-to-day variation in this patient. Said that about in the day of dialysis there may be a significant reduction, about 25% in the dose of the basal insulin. So this patient will suffer from day-to-day variation and inter-day variation as well. The day of dialysis, the patient may suffer from hypoglycemia on the dialysis session, followed by hyperglycemia at night. This glucose variability are highly associated with cardiovascular complication and increasing mortality in this patient. So in conclusion, glycemic control is complex in this patient. These patients are highly susceptible to hypoglycemia. Diabetic pharmacotherapy should be individualized to each patient. For most hemodialysis patients, insulin is the preferred rather than oral hypoglycemic. The insulin analogues are more favorable, but the cost is the barrier. If we want to use oral hypoglycemic in type 2 diabetes on dialysis, we will use Meglitinides or Biguanides. Hemoglobin A1C, although or apart from all the criticism to this hemoglobin A1C, it's still the one best used to monitor the patient with monitor the glycemic control in patient on dialysis. And thank you.
Thank you, Professor Ghada, for a very excellent talk about diabetes and renal failure. And now it's open for discussion.
I have a question about patient, diabetic patient with end-stage kidney disease, but who are not in hemodialysis. Many times I found that they normalize the glycemia and I stop the treatment, even the regime. I would like to know what is about that, because I have many patients who are in that state. Why? At a certain moment, the glycemia is normal.
The treatment of the patient is normal glycemic.
Yeah, is normal glycemia, and then.
So this is a common complication in diabetes. Even when we teach the undergraduate, we say that the causes of hypoglycemia, the first cause is the use of oral hypoglycemic or insulin, it is drug related. The second cause is renal failure. So kidney disease, at first, the earlier stages, there may be increase in the insulin resistance. Later, as the kidney fails more and more, there will be decrease in the clearance of insulin. We all know that insulin is released from the kidney. So the insulin will be provided to the patient more and more. He has endogenous sufficient insulin. Besides, the kidney is one of the gluconeogenic organs. So as the kidney fails, there will be decrease in the production of glucose. This is why at the beginning of renal impairment, there may be increase in the insulin resistance and increase in the glucose level and hyperglycemia. Later on, as the patient reaches the end stage, there will be decrease in clearance of insulin. The insulin level will increase and the gluconeogenesis will be suppressed, so glucose level will be not the same. So the patient may suffer from recurrent attacks of hypoglycemia. And if I have a patient, a diabetic patient, with recurrent attacks of hypoglycemia that makes the patient even stop the drug, I should suspect that this patient is in kidney disease, is in chronic kidney disease.
The second question is about a patient diabetic, but this time they are in hemodialysis. Is there any evidence? Because during the dialysis session, their glucose can easily move. Is there any evidence that we can treat that diabetes with free dialysis glucose. There are studies who have been done to show that those patients can be only treated with hemodialysis, and then at the same time they don't need medication or regime.
So this is different. When the patient starts dialysis, usually the condition differs. As you mentioned, at the day of the dialysis, the patient in the morning is in the worst state. The higher, can you imagine that the higher the blood glucose in the morning, the more the hypo. So when I have a glucose-free dialysate, this high glucose level will be shifted by osmolarity to the dialysate, and the patient will suffer from more hypoglycemia. So if we have the chance to use the 100 milligram glucose-containing dialysate, it will be better than the glucose-free one.
And as a teaching point here, as Professor Ghada said, if the blood don't rush with the insulin therapy, you will find high blood sugar at the start of dialysis session, because this could be decreased at the end of dialysis session due to loss of glucose in dialysate. And also, the second point, as raised by Dr. Ghada, regarding post-dialysis hyperglycemia due to counter-regulatory hormones, which can increase also the blood glucose due to counter-regulatory hormones. But don't rush, don't try to be very accurate regarding the use of insulin during dialysis session. Hyperglycemia as a start could be decreased at the end of dialysis, and post-dialysis hyperglycemia could be related to counter-regulatory hormones. And it is better also, as Dr. Ghada said, to decrease the dose of long-acting insulin on the night before the day of dialysis. It is very important to decrease the dose of long-acting insulin the day before dialysis for more control of blood glucose. Dr. Ghada also regarding pioglitazone. Pioglitazone, yes, since about 5 years there is a lot of everyday concern regarding cancer bladder. But I think since about 2 years this concern decreased again, and the incidence of cancer bladder with pioglitazone is not significantly higher. Yes, but at least pioglitazone we will not use in presence of microscopic hematuria or microscopic or macroscopic hematuria, or in families with patients with family history of pregnancy, or patients with the cancer bladder before. We try to keep the pioglitazone away. Like pioglitazone also, due to salt water retention, can increase salt water retention in patients with chronic renal failure. The last point, which is very, very important, as Dr. Ghada said now, the diagnosis and the management of diabetic ketoacidosis, because our patient, very uncommon to find patients with diabetic ketoacidosis and diabetic dialysis patients, because those patients, first of all, an insulin half-life time increase in dialysis patients. Number two, and I always see these patients 3 times a week, and you can check your blood glucose, but this patient can be presented with diabetic ketoacidosis, especially the patient anuric. We cannot test for acetone in urine, but this patient can come with, as Dr. Ghada said, severe hyperglycemia, maybe pulmonary edema because this patient, there is no polyuria because the patient is anuric, and marked acidosis with severe hyperkalemia. So on those patients also, you can shift this patient to dialysis for management of this severe acidosis and hyperkalemia, and afterward you can control blood sugar, because we cannot give fluids for those patients because they are anuric. It is very important points from practical point of view, as Dr. Ghada said now. Any other questions?
Thank you. My name is Dr. Hamzu. At first, I would like to thank the director for his presentation. So, Professor, I thank you also for your explication. So, I was talking about the common care. We are in common care for the patient. We're supposed to care the patient for all the dialysis or everything. So, I mean, as you see, it will be a burden for the nephrologist to take care about the dialysis and also diabetes. So, at one time, we can send the patient to the diabetologist or to call him in order to take care for the patient also. So I mean we have to work in common care. Thank you.
What time will the patient to the diabetologist? When to put out? Dr. Ghada is diabetologist also, and a nephrologist.
So when the question is about when to refer your patient. Yeah, so it is better to have a teamwork from the start. Once the patient with diabetes start hemodialysis, it is wise to work together. Yeah, to achieve the optimal control of your patient. And you should refer your patient anytime that you found that yourself that you are not cope with the patient condition. I think that diabetic ketoacidosis and the management of diabetic ketoacidosis, although it is rare in this patient, but I think that the diabetologist will be more, let's say, more experienced in managing such cases with the care of hyperkalemia and how to manage this patient, except if the patient needs dialysis. So teamwork is from the start, yeah.
Yes.
Thank you so much, Professor, for the presentation. I know that you mentioned others sulfonylureas that Glycated is one of those good drugs to use. But my experience where I come from is that this drug is a bit expensive and it's a challenge for most patients to get it. What is very common there is under this group of all hypoglycemics, the commonly called diabetic.
The trade name in Egypt is Meglitinides, and it is not present nowadays. It is one of the short-acting sulfonylurea. Duanil is glycaemic, and it is a long-acting, and it is completely contraindicated in this patient. As I said that sulfonylurea have a high protein bound. They are not released during dialysis. Carries long-acting one carries more in general population, not in dialysis patient as well. Long-acting sulfonylurea are the one which are accused. The first side effect is hypoglycemia. So never to use long-acting sulfonylurea in such patient. Hypoglycemia produced by sulfonylurea in end-stage kidney disease and in patient on dialysis may need a long time for treatment, up to 10 days. These patients, the drug is released gradually from its protein binding, resulting in more and more recurrent hypoglycemia. So patient with dialysis on long-acting sulfonylurea and suffers from hypoglycemia should be admitted. Never to let this patient to go back home once his blood sugar is controlled. You should supervise your patient.
Any medication secreted mainly by the kidney should be avoided in patients with renal failure. And any medication metabolized by the liver, but the metabolite is still active, also contraindicated. The main indicated drug is the drug which is metabolized by the liver mainly to inactive metabolite.
Merci pour votre exposé. Oui, moi, merci bien. J'ai deux questions. La première question, c'est concernant les patients diabétiques qui vont en dialyse. La plupart de ces patients chez nous sont déséquilibrés sur le plan de vue de la glycémie. Et on sait que dans le bain de dialyse, le dialysat, il y a, n'est-ce pas, du glucose. Donc, très souvent, quand il y a des séances de dialyse, il y a des patients qui peuvent se retrouver soit en hypo ou en hyperglycémie. Mais généralement, ils se retrouvent en hypoglycémie. Qu'est-ce que vous faites pour l'insuline chez les patients qui sont à la dialyse? Quelles sont les recommandations pratiques que vous leur donnez pour éviter surtout les épisodes d'hypoglycémie? Ça, c'est ma première question. Et si je peux me permettre la deuxième question, c'est...
Excuse me. Regarding your question about the hypoglycemia, we should consider interstitial disease and dialysis per se is a risk factor for hypoglycemia. So the only way to avoid the occurrence of hypoglycemia is frequent monitoring of plasma glucose. And when we depend upon glycosylated hemoglobin, it is better to relax our control. Instead of 6 or 6.5% in general population, here even 7 or more. If the patient has, if we say around 7% is okay, and the patient history shows a hypoglycemic episode, we should be more relaxed. Even we can accept A1C above 7%, even up to 8%. So the best way to avoid hypoglycemia is proper history taking and frequent monitoring of plasma glucose and some relaxation of diabetic control, and overall revision of all drugs. As my Professor Samir mentioned, that the drugs they may interact with the antihyperglycemic drugs, the metabolites of antihyperglycemic drugs. All this can lead to hypoglycemia. So we should be careful about the use of anti-diabetic drugs and all medications the patient receives. This is regarding the first question. What about your second question, last question? Okay.
La deuxième question, c'est justement concernant l'hémoglobine glyquée. L'hémoglobine glyquée. On sait qu'au cours du diabète, il y a l'anémie, il y a d'autres, plutôt au cours de l'insuffisance rénale, il y a l'anémie, il y a d'autres modifications qui s'opèrent, qui contribuent à diminuer l'importance de l'hémoglobine glyquée. Est-ce qu'il existe autre chose, un autre paramètre que l'on peut utiliser pour avoir une idée de l'efficacité du contrôle glycémique du patient? Quelque chose qui est accessible. Je ne dis pas les trucs de la recherche labo, mais quelque chose d'accessible.
Regarding the glycemic control in end-stage kidney disease and dialysis, I agree 100% with you that glycosylated A1C is not an accurate index of glycemic control in end-stage kidney disease or on dialysis, but it's still practical. Yes, some factors can falsely increase the level of A1C, like as you said, anemia and uremia, because it will interfere with the test. And treating anemia by iron therapy or erythropoiesis stimulating agents can give false low levels of A1C. But at the end of the day, it is a practical way, and we look at serial levels. And if we think of an alternative like glycated albumin, glycated albumin is also with fallacies, and it is more expensive and not available in many laboratories, and also includes false high and false low. So for practical reasons, we use both glycated A1C and frequent monitoring of plasma glucose. Both of them are practical and available with us.
Clear in the lecture that Dr. Hussein say that hemoglobin A1C is not free from disadvantage, being short accessible glycemic control and short duration, affected in proteinuria patients, and there is no clinical trials that link the glycemic control with the glycated albumin to the chronic complication of diabetes. So hemoglobin A1C is still the cornerstone, and it is a good choice for assessing the control in these patients.
I think from a practical point of view, the most important monitor for blood sugar is to encourage your patients to check HGT every now and then, 3 times before meals and the 4th time before sleeping. It is very important to depend on frequent checking of HGT for chronic renal failure patients. Don't depend on glycated hemoglobin alone or glycated albumin alone. Please, you must encourage and you must educate your patients about using a glucometer and to check HGT 4 times per day, 3 times before meals, and the 4th time before sleep.
Yes. So for monitoring of blood glucose, I can, for a patient receiving oral hypoglycemic drugs, we usually depend on the fasting level. So infrequent assessment, this is the general population, infrequent assessment of the fasting level in patient on oral hypoglycemic with some check of the postprandial blood glucose level once or twice may be sufficient. In patients on insulin therapy, we should check, we should do 4 samples, as Dr. Samir said, 2 days a week, at least 2 days a week, including the fasting one and the one at night, and to modify the insulin dose according to these levels.
So if we put an MSQ question, what is the breakthrough in management of diabetes through the last 50 years, it is the presence of glucometer and frequent checking of plasma glucose. And currently, FDA approved a continuous glucometer inserted within the patient and connected electronically with his doctor, just to check and treat. So don't forget to frequent checking of plasma glucose, especially if you have a patient with documented episodes of hypoglycemia.
One point of importance here, Dr. Hussein, is that the patient, if the patient suffers from recurrent attacks of hypoglycemia, you reach the point of hypoglycemic unawareness. And this can be prevented by frequent monitoring of the blood glucose, especially when we say the schedule on insulin 4 times per day, at least 2 days a week, 2 days in a week. But once the patient feels symptoms of hypoglycemia, he should check his blood glucose, because repeated hypos will result in hypoglycemic unawareness. This means hypoglycemia without symptoms, and this is the danger part. Thank you.
To the next lecture.
Thank you very much, Professor Ghada, for your elegant talk and fruitful discussion. Thank you very much. It is my pleasure.